Hypoglycemia is one of the major complications in children with severe acute malnutrition. All severely malnourished children are at risk of developing hypoglycemia. It can occur as a sequelae of a serious systemic infection or if a malnourished child has not been fed for a long period of time, such as 4 to 6 hours. This usually happens when severely malnourished children travel for long hours or spend long hours without medical care at health facilities. Hypoglycemia in children with severe acute malnutrition is defined as a glucometer of less than 3 millimoles per liter. Signs of hypoglycemia in children with severe acute malnutrition include the following: a low body temperature, which is defined as an axillary temperature of less than 36.5 degrees Celsius, lethargy or drowsiness, loss of consciousness or convulsions, or other abnormal movements, including jitteriness. Of note, it is important to remember that children with severe acute malnutrition rarely show other symptoms of hypoglycemia, such as sweating or pallor, due to physiological changes which occur in their system and may dampen these signs. Prevention of hypoglycemia is critical in children with severe acute malnutrition. In order to prevent hypoglycemia, a child with severe acute malnutrition should be given F75 as the initial feed as soon as a diagnosis of severe acute malnutrition is made, either in casualty or in the outpatient department. If F75 is not available, sugar water can be given. If hypoglycemia is suspected, treat. Immediate treatment of hypoglycemia should be done even without laboratory confirmation. It does not harm the child. The management of hypoglycemia can be summarized using the following algorithm. If a child is conscious and has a glucometer reading that shows less than 3 millimoles per liter, give a 50 milliliter bolus of 10% glucose or 10% sucrose solution, which is 1 rounded teaspoon of sugar in 3.5 tablespoons of water. Give this orally or by nasogastric tube. Then give the first feed of F75 therapeutic milk and give it frequently, every 30 minutes for 2 hours, giving 1/4 of the 2-hourly feed each time. Then continue with 2-hourly feeds day and night. Start management of infections. Hypoglycemia can be a sign of severe infection. If the child is unconscious, lethargic, or convulsing, give IV sterile 10% glucose at 5 milliliters per kilogram, followed by 50 milliliters of 10% glucose, or 10% sucrose by nasogastric tube. Then give the initial feed of F75 therapeutic milk and continue as above. Start broad-spectrum antibiotics to manage infections. Continue 2-hourly feeds day and night. Monitor the following during the management of a child with hypoglycemia and severe acute malnutrition. Blood glucose. If this is low, repeat the glucometer reading, taking blood from the finger or the heel after 2 hours. Once treated, most children stabilize within 30 minutes. If blood glucose falls to less than 3 millimoles per liter, give a further 50 ml bolus of 10% glucose or sucrose solution and continue feeding every 30 minutes until stable. Axillary temperature. If this falls to below 36.5 degrees Celsius, repeat the glucometer reading, and if the blood glucose is less than 3 millimoles per liter, manage as above. Level of consciousness. If this deteriorates, repeat the glucometer reading. If it is low or less than 3 millimoles per liter, manage as above. Note well, if hypoglycemia persists, aggressively manage hypothermia and severe infection and refer the patient.